Okay, so friends, it's my pleasure to introduce Dr. Rajeev Jayadevan. Dr. Rajeev is MBBS and MD graduate from CMC Vellore, and was the best outgoing student of his batch for MBBS as well as for MD. A very lovely person, very kind, generous with his time. And if you read his website and blogs, you know that he likes to share his knowledge. Subsequently, he has trained in UK as well as in US, and he's a brilliant gastroenterologist. And he's also in charge of the IMA in his area. And he likes to impart his knowledge and share his knowledge with as many people as possible. Rajeev is also a close friend of our department and a personal friend of mine. I was his intern, and it was a pleasure to have worked with Rajeev. And we are deeply honored today that he will take a class on non-alcoholic steatohepatitis or Nash. So it's becoming an important topic in India. It's probably replacing alcohol as a common cause of liver disease, depending on where you are. And there seems to be so many new information on Nash, especially lean people with Nash and other things, that we thought Rajeev is the opt person to teach us this. So I'll hand you over to Rajeev, and please write down the questions which you have as comments in a paper, or you can post it on the Zoom chat box so that we don't disturb the session. When the session is over, then you can, I hope Rajeev will stay behind with us and answer as many questions as possible. So
Definitely.
with that minimum introduction, Rajeev, it's a pleasure. Thank you again. And I'll hand all of you over to Rajeev. Thanks, Rajeev.
Thank you, Tambu.
Okay.
It's such a pleasure. It's lovely to be back home, and thank you for the invite. So the session is still 3 o'clock, right? Does that include question time?
Yeah. Yes, sir.
Yeah.
You can go beyond 3 also.
Yeah. So I'll stop a little before 3.
Sure.
And then we'll take some questions,
sure,
and we'll see if we can answer them together.
Sure. Sure. Thank you.
So welcome to all. Thank you for the invitation, and also to all of the audience. I know everybody is a busy doctor, and if you made the time, I'm grateful, and I'll try to make it worthwhile your time as well. So when we talk about fatty liver, I'll just use common terms, fatty liver. We have innumerable lectures. There are so many textbooks, there are chapters. So if anyone wants to know about fatty liver, all they need to do is to open Harrison's or Davidson, and there are beautiful chapters. So I wondered, what could I do differently today? So since the audience is primarily postgraduates in medicine, what we were a few years ago, I've geared my talk towards that particular segment, with a lot of information which will help the others as well, including the seniors. And as you will see through my presentation, it is pretty unconventional. So just sit back and enjoy. That's all I will say. Right? So I will start with the conclusions. So I'm known for atypical presentations. So I'll start with the conclusions, assuming that the target audience is here. The first conclusion is that in medicine, we often try to put things or pack things, fit things inside boxes. Things don't really fit boxes anymore. The more you look at it, more diseases are found, and diseases are, after all, man-made names. But when we try to put names like Nash, Nafld, fatty liver, alcoholic steatohepatitis, they don't all fit into a single box or single individual box. So that's the first lesson. The first lesson is it is good to learn about the disease, but when the patient comes to you, the patient's not coming to you with a box. The patient may have multiple boxes which may sometimes be connected with each other. So that is the rule number 1. Never expect a diagnosis out of a box for a patient. That is, again, as Tambu will agree, I'm talking from experience as how we assimilated knowledge and experience over the years. The second lesson or second conclusion is increasingly the world is becoming a pill-based society or a tablet-based society. Society at large expects doctors to have a pill as an answer for every disease. Anything ranging from tuberculosis to AIDS to diabetes to heart disease, to stroke, anything society expects a disease, a pill as an answer. And the latest is COVID. See, people spend hours discussing what is the best antiviral treatment, while they completely ignore the public health recommendations that are perhaps more important for the general public. So public is wasting time debating on remdesivir and other such agents, whereas they will have, they totally flout all the other social distancing guidelines. And they're not convinced when you explain to them all that's needed is right now you stay safe. So we are a pill-based society, and as the postgraduates become consultants and start seeing patients on their own, you will discover that with patients as well. So remember that patients are coming to you with an expectation for a pill, and sometimes that can put you in a bit of a difficult situation. Right? Number third is that when we deal with fatty liver is really the tip of an iceberg. When you see a patient with a fatty liver, we are actually looking only at the tip of an iceberg. So the next time you see a patient, I want you to know, just think of the iceberg. When the iceberg is floating in the sea, we've only seen pictures and movies. We know that the majority of the iceberg is under the water, which means we can't see. So we use the expression tip of the iceberg to explain that what you see is not what there is. There's a lot more to the problem than what you can see. So what is beneath the iceberg is something that I will get into. On the tip is the fatty liver. And as you look deeper, you will discover heart disease, you will discover diabetes, you will discover hypertension, you will discover alcoholism, hyperlipidemia, insulin sensitivity related issues, and obesity. And multiple other conditions which may come linked with those. So which again goes to my first point, we can't really fit these patients into boxes. And number four, I would like everyone to remember the number 10. 10 is the cure number for fatty liver. 10 is 10%. If you can get your patient to lose 10% of their weight, you have cured the disease. So keep that in mind. If you remember nothing else from my talk for a very long time, keep the number 10 in your mind. So 3 is good, 5 is better, 7 is even better, 10 is best in terms of percentages. So if a patient comes to you and weighs 70 kilograms, you put a target and say, look, over the next several months, I want you to come down to 63 kilograms. That is 70 minus 7. That is 10% of 70, all right? So that is 10. Remember the number 10. And you might have come across the new literature that, you know, in medicine, the terms keep changing. The diseases remain the same, but the terms keep changing. So now there is a move to rename this fatty liver or Nafld as Mafld, M for mother, M-A-F-L-D, M for metabolism. So the new term will most likely be Mafld or metabolic associated fatty liver disease. Why is this change important? I believe it's a good move because if you use the term fatty liver, it's a very bland and unscientific term. It gives no, it gives no meaning to it. Even if you say non-alcoholic, it simply has no meaning. In fact, it's a silly term, NAFLD. So metabolic associated fatty liver disease provides a bit of meaning to it, not only the patient, but also to the doctor. So the doctor can focus more on the metabolism. So watch out for this term called Mafld. And conclusion number 6 is when you deal with patients with fatty liver, it is not like treating somebody for deworming. When you do deworming, you give them a tablet of albendazole and you're done with it. And that's it. So, but with fatty liver, it is a long association. It's the beginning of a long association. So I would like people to keep that in mind. Many of you will end up in very busy practices and you will see fatty liver after fatty liver and after fatty liver. But each patient is different and each patient will provide opportunities and challenges, and it will be interesting to dissect each patient out when the time permits. And if time does not permit on one day, bring the patient back another day when you're not so busy and sort the patient out. So fatty liver, unlike a case of helminthiasis, is a disease or a condition that requires follow-up. That is my point. So don't send them away and say, look, you don't come back. You make sure they come back and you sort the problem out one by one. And it takes a long time to sort a patient with fatty liver out, even though it sounds like a benign and rather silly diagnosis. So that is the point number 6. And number 7 is, I'll say this, you can see the most advanced cirrhosis patient, but you will have a normal liver function test. So what we call liver function test, or LFT, is a poor marker of the actual functioning of the liver. LFTs are basically a collection of numbers which somebody put together a long time ago, and they have remained a collection for a long time and they haven't changed. Some traditions don't change. But if you really look at them, none of them, apart from albumin, none of them show the function of the liver. Some of them are injury markers, and others may reflect a little bit of the canalicular function of the liver. But if someone tells you that it's a liver function test, remember to politely correct them and say it is liver test LT, not LFT. So the F has to be deleted. We've been saying that for 25 years, but nothing has changed. But LFT rhymes very nicely. But remember, LFT is a poor test, especially for prognostication. And you can see a patient, as I mentioned, with liver cirrhosis, full-fledged liver cirrhosis, perfectly normal liver function test. And vice versa as well. You could see a reasonably healthy individual with abnormal numbers as well. So unlike a pregnancy test, which has good discriminatory value, a pregnancy test is a good test. Why? Because it differentiates somebody who is pregnant from those who are not pregnant. So it's got a very high discriminating value. Whereas an LFT is very poor at differentiating one condition from the other. But within its limitations, people have played around with some numbers and created formulae, and I will get into that during my discussion. So those are the main points. So now let's, because it is again for the postgraduates, I will invite you to a new way of thinking. I'm sure Tambu and company have discussed this way of thinking to you, but let me just present something new to you. I hope you're familiar with the concept of root cause analysis. Root cause analysis, or RCA, is also called critical thinking. Critical thinking is as follows. I'll give you an example. Basically, it involves asking the question why repeatedly until we find an answer. Why should you ask the question why repeatedly? The reason is, unless you ask repeatedly, you may not uncover the root cause of the problem. And remember, if we don't identify the root cause of the problem does not go away. And in the context of fatty liver, this concept is important. And not only with fatty liver, with everything, even with the ongoing pandemic, root cause analysis is extremely important. So I'll give you one example of root cause analysis, which is used in teaching modules. In Washington, D.C., that is the capital of America, stands a monument which is extremely tall and shaped like a pencil. It is called the Washington Monument. It is over 100 feet tall and really majestic, and it is surrounded by majestic gardens, and that is the place where the great Martin Luther King gave his historic speech, "I have a dream." So Washington Monument is very precious for the Americans. Somebody made an observation that the Washington Monument was getting tarnished, and they were having to periodically clean it or refurbish it. And it was causing considerable expense because it's an ancient monument, and people are having difficulty maintaining it. So they tried to find out, why is this monument, just like our Taj Mahal? Taj Mahal, it's getting stained. Same way, the Washington Monument was deteriorating. So they sent a team to find out what is happening. The team came back and gave a report and said it's only because they are actually using some caustic cleaning agents to clean the monument, to clean the surface of the monument. So they said that's fine, because then stop using the cleaning agent. Then somebody asked the question, why are they using the cleaning agent? And then they went back and found the answer. They found that the cleaning agent was necessary because a certain kind of bird was defecating on the monument, and they would come to the monument in large numbers, and their droppings required this particular cleaning agent. Then somebody said, why are the birds coming to the monument? Can't you drive them away? So they went and found out that the birds actually are coming because this monument has plenty of spiders. There are spiders that are hiding in the crevices, and the birds come and eat the spiders. So the birds come searching for food. Then somebody had the bright idea, why don't we apply some insecticide on the spiders and we'll get rid of it. Then somebody asked the question, why are the spiders there? And they found that the spiders were enjoying a meal of a particular kind of insect that would come in the evening. So they asked the question about why the spiders were thriving, and they found that the spiders were having plenty of food because every evening insects from all around that area would flock onto the monument. So then somebody asked the final question, that's the fifth why in this question, in this problem, that is, why are the insects coming? And then they found out that the insects were coming to the monument because in the evening, when the sun went down, the first monument to be lit up was the Washington Monument. So the lights first came on in the Washington Monument compared to other buildings. So what do the insects do? They always get attracted to light. They flew at the first sign of light, and they all flocked to the Washington Monument. So then finally, after all these questions, they found a solution. They said, you know what? There is a simple solution to this problem. Just don't turn the light on in the Washington Monument until lights are turned on in all other buildings in that area. So they adjusted the timings of the lighting, adjusting it to half an hour after the adjacent buildings. And the insects stopped coming, the spiders died, the birds were not interested anymore, there were no more droppings, no more cleaning needed, and the Washington Monument survived. So this is the textbook example of root cause analysis. So this can be applied, as I mentioned, to almost all the cases that you see. Now, I'm not here to preach to you and say, if you sit in a very busy outpatient, you can do a root cause analysis on all the patients. But remember to keep the machinery on, keep the program running, so that when the need arises, you will always be able to do critical thinking. Now, critical thinking need not always apply to medicine. It can apply to, any problem at work, problem in personal life, problem in society. You could apply that. But unfortunately, in our part of the world, critical thinking is not given a lot of importance because our education system is very memory-based. We are asked to memorize facts. In medicine, we are made to remember the 10 causes of diastolic murmurs, things like that. While they are important, it's also important that we do critical thinking, and that's where Vellore stood out. Vellore, we were consistently taught to do critical thinking and also problem listing. I remember Dr. Dilip Mathai insisting on problem listing, and problem listing, I think he imported it from some Western university that he had attended. And he was, as I recall, insisting on problem listing, which I continued in my practice when I moved to the UK. And the people in the UK were impressed at my problem listing. Problem listing is simple. If you have a problem, if you have a patient with fever, you list the patient's problems are A, fever, B, patient has a headache, C, the patient has an allergy to paracetamol, 4, the patient has a blood culture that is inconclusive. So those are the problems, and you update them every day or every other day, and so on till the patient is discharged. Same way, we can create a problem list for our patients, especially the difficult to solve problems that we see in the clinic. So that is the root cause analysis. So now let's go to a real life scenario. Imagine that now you're sitting in your clinic and a 36-year-old IT professional, a information technology professional is walking into a consulting room with a big file. We call them the Google patient, all right? They come with a big file of downloaded, quote unquote, research papers. They have done all their research. They have done a company checkup, and their ultrasound scan, which was done for no reason, unfortunately has shown fatty liver, and he wants your opinion on it. So that is your typical patient when you practice in a city. So here is the patient. He's 36 years old. He's 160 centimeters tall and 70 kilograms in weight. And that patient is sitting in front of you. And let's see how we approach this problem. So let's assume that you're not very pressed for time. You got about, maybe you got about 7, 8, maybe even 10 minutes for this patient, because it's a new patient. In the US, you'll be spending a half an hour for that patient, but India, we don't have that luxury. So what approach will you take? I want you to just pause for a couple of seconds and think how you will approach this problem. Let's pause for a second. When a patient comes in front of us, instinct is to reach out for the pen and start writing a prescription. That is what the majority of doctors do in the areas that I have seen. You can't say right or wrong there, but if you reach for your pen before you make a diagnosis, if you reach for your pen before you know what is wrong with the patient, and you have no interest in solving the original problem, then I believe that you have failed as a doctor. Again, it is impossible to solve everybody's problems, but we need to really think beyond what is the obvious and look beyond the obvious to solve the patient's problem. So I'll explain how I approach a patient, and this is what I've been taught mainly at Vellore. Dr. Benjamin Pulmo, Dr. M. Cherian, all these, Dr. Lily John, all these people have given us a lot of insight on how to approach patients, and Dr. O.C. Abraham's knowledge on differential diagnosis and his sharpness and his clinical skills. All these things are things that we took home after we finished our MD medicine. So when we approach a patient, we are not really looking at a diagnosis right now. We want to say, what I would think is, with all my years of practice, I'll think, what made this person come to see me? See, a patient, you may see 10 patients who have the same diagnosis of fatty liver, but each one of them would have come to you in a different circumstance. The thoughts on their minds, what prompted them to come to you, will be all different. So that's an art. I call it the art of medicine. It's about finding out where they're coming from, what they do, what their fears are, what they expect from you. Some patients come with an expectation of reassurance. Some patients come to you because they're anxious. Some people come to you because they're paranoid or they're afraid of something they read on the internet. Some people come to you because their colleague was diagnosed with a problem, and others have a family member that has had a similar problem, or may have seen a television show or a movie that alarmed them about a particular disease. Or they may have watched a television show where a doctor was sitting on television and talking about some diseases. So there are any number of causes that a patient would come to you for a fatty liver. Now, when somebody comes to you with abdominal pain, the patient is coming to you because the patient developed pain. I'm talking about a patient with fatty liver or something else. So it's important to find out, ask, you don't have to ask like the police force, like, why are you here? You don't have to do that. But if you just sit back and listen a little bit, don't interrupt them for the first minute, you'll be able to get some cues. And second is to remember that we have the power. As the doctor, we have the power to change this person's destiny. Now, by destiny, I mean how long this person will live, even what this person would die of. Now, that may sound very dramatic, but let me take you to the second question. The average longevity varies anywhere from 65 to 75 in India. And that doesn't mean that everybody dies at 75 or anything. Some people die sooner. And why do they die sooner? And that is why we have to list the causes of death. The causes of death: 1 out of 3 people die from ischemic heart disease. 1 out of 6 die of cancer. And among cancers, the top killer among cancer is lung cancer. It is believed that liver cancer may be number 2, depending on what series you read. So here we have an opportunity to A, prolong this person's life by preventing heart disease in him, and second, by preventing chronic liver disease as well as liver cancer in this individual. Did you ever think like that when you saw a patient with fatty liver? I'll bet you don't. That is a new kind of thinking I want you to get into. I'll give you a story. When I was in the US, I did my residency and my gastro fellowship in the US. I used to watch the FBI crime files. They had a program called FBI's Most Wanted. FBI is the crime, Federal Bureau of Investigation. So they have a list of the most wanted criminals, and they would come on television and put a photograph and say, have you ever seen this person? This person has been missing for 35 years and is wanted for the most heinous crime, and they'll describe the crime, which is what everybody's tuning in for. They want to know what they did. So in the pictures, I've noticed in one instance, they showed a picture of a beautiful woman, and then they said, this woman was last seen 35 years ago, and this person might look like this. And then they showed a picture of an older woman who was obese and looked like she had some kind of a disease. And then they showed another picture and they said this person could also look like this. That person looked more elegant, looked younger, but of the same age. Now, how could one woman become two faces in 35 years? That's a question. So that is when I looked into their methodology, and I found that they have something called face restructuring technology. What they do is they take the picture of somebody who's young and they put it through some sort of a computer model, and they put in all the variables. Say, if this person was a drinker, what this person would look like in 25 years or 35 years. What this person would look like if that person took care of themselves, if that person took care of their health, was exercising, ate sensibly, did not drink or smoke, did not use drug, what that person would look like. So but my point is that for this patient who's sitting in front of you at the age of 36, you could be looking at a choice of 3 or 4 different pictures 30 years from now. That person may look like a completely cirrhotic, cachexic individual with liver cancer. That person could look like an elegant 65-year-old man with who looked like he's 40 and is in excellent shape. And that person could look like a completely overweight, darkened, double-chinned person who's got a large belly and has diabetes and is taking insulin. Now, all of these possibilities, remember, are sitting on the chair in front of you when the patient is in front of you. And it depends on your ability and your interest and skill as a doctor to decide for that patient which picture you want that patient to be. So which is why I said, if we reach for that pen and paper, the moment the patient walks in and write ursodeoxycholic acid 300 twice daily for 3 months, you're not going to do any favor to this patient. You will not make any difference to the patient's long-term outlook. So that is the message I want you to take back home. Remember the FBI crime files. Remember that for every patient, especially younger patient who comes to you, you have the power to alter their future. Remember those old pictures which are of different faces, and you want that patient, because he is your patient, she is your patient, to look like the healthy, young-looking 65-year-old 30 years from now. So that is, again, that FBI story that I wanted to share. So let's go to the questions. The patient is sitting in front of you and you want to ask some questions. So what are the questions that we would want to ask? Naturally, the patient develops fatty liver because A, the patient is on a sedentary job. Most Indians are doing sedentary jobs now, and it's only going to increase as time goes on. So sedentary jobs are quite common. The patient's dietary habits may not be very healthy, and people choose to eat what they want to eat, and it may not necessarily be healthy. So that's number 2. Number 3 is a very, very important question. Does this patient drink is the question. So how do you ask that question? You ask him, excuse me, sir, do you drink alcohol? What do you think the patient is going to tell you? Hey, absolutely not. I don't drink at all. The patient may deny alcohol for many reasons. 1, he wants to create a good rapport with you. The patient may be afraid that you may yell at him. 2nd, the patient may be afraid of an insurance claim, because now many people are coming with health insurance. If you record alcohol in your clinic notes, somebody might have told the patient, look, don't admit the history of alcohol. So how do you detect if the patient is a drinker or not? So the first is to actually use common sense. If you look at the patient very carefully, you can see some traits of drinkers. There are some universal traits of drinkers. And if you've seen enough drinkers, you will know what they look like. they may look very sociable. Drinkers are typically extremely sociable, very lovely people. They're very endearing, and they talk smooth. They talk really smooth because they've been to many doctors and they know how to deal with the doctor. They're never awkward when they talk with you. And some of them will walk into you with a whiff of alcohol. You can smell that spirit. Like, I don't drink, but I'm trained to detect the smell of alcohol because you can detect that whiff of alcohol. They may have walked to the nearby bar and taken a couple of pegs before coming into your office. So those are the simple methods of detecting alcohol. The other is to look for the wife. When you are taking the history, when you ask the patient, instead of asking how do you drink alcohol, you ask him how much alcohol do you drink, and then you watch their facial expressions. As doctors, I believe that we are very good at lie detection. I believe I'm extremely good at detecting a lie. I don't think anyone can get past me by lying at me because I believe I'm good at that. And there's no single method to that. If you read the textbook, they'll mislead you because the body language they teach you about lie detection is all wrong because they're all culture based. But if you look at the patient, if the patient is looking away, if the patient has a sudden change in the tone, no, I don't drink, or the patient looking down, or the patient gives an exaggerated response, those are typical signs of lying. So even better is to look at the wife. The wife will always give that suggestive expression on her face saying, no, he drinks. They may give you that subtle nod. They don't want the husband to see the nod, but they'll invariably look at you because you are their last hope. That guy may be a drunkard. They may be having domestic issues at home, and this may be the first time he or she is getting some help. So keep an eye out for alcoholism. Alcoholism is a deep subject. This is not the venue to get into that. We don't have time to get into that, but alcoholism is extremely deep. I'll invite you to read Dr. Salim Yusuf's paper in the Lancet about the use of alcohol in developing nations. It'll open your eyes like never before. All the glorifications you heard about alcohol will vanish. Alcohol is actually a major cause of cancer and deaths in the developing world. So keep that in mind. So uncover alcohol is one. And then you can ask the patient the traditional questions. Is there a family history? Instead of asking, is there a family history, I tend to ask, who else in your family has liver disease? See, the way of asking a question is extremely important. If you ask them, is there, they will say no. If you ask them, who else in your family has this problem, then you will make them think. So keep that in mind. So sometimes if you are really confident, you can ask them, how much alcohol do you drink in a day? And that will get them to talking. And as a rule, I don't yell at any of my patients. Even if they don't follow my advice about alcohol, I don't shout at them at all because it's their life. So once you develop that rapport with the patient, they will be able to open up to you better. All right. So these are some of the questions that you want to ask. Again, I'm not here to take a clinic for you, but remember that after you take your history, you want to examine the patient. And while examining the patient, the first thing you would examine will be the patient's face. And people with chronic liver disease tend to have a peculiar kind of a face. Their face undergoes some sort of a spontaneous remodeling. You will know when you've seen enough cirrhotic patients, they'll all have a similar face. And it's a peculiar kind of muscle wasting that makes them a little prolonged, and they have a longer neck and they'll have darker complexion. And their spouse may tell you the person has become darker over the years. You can also spot spider nevi. I don't have to explain spider nevi to you because you're a medicine PG at CMC Vellore, because the number of spiders that you've seen will be beyond I can count. The other clinical examination that I will invite you to do is something called, in addition to the height and weight, I'll invite you to do what is called the waist circumference. The waist, the anterior superior iliac spine, ASIA, so the top of iliac crest. Take a tape around the top of the iliac crest and you measure the waist circumference. And it should be less than 90 for a man and less than 85 for a non-pregnant woman. So keep that in mind, 85 and 90 centimeters. Waist circumference is an extremely important marker. It's perhaps more important than BMI when we deal with patients. Now let's imagine we're sitting in a busy clinic and we don't have the time to calculate BMI. How do you know if the height and weight are matching? I'll give you a secret and simple formula. Your nurse tells you, or it's written in the chart, the patient's height is 160 centimeters. Here's a magic formula. You just subtract 100 from it. If you subtract 100 from 160, you get 60, and 60 or below will be the ideal weight. So this is a ballpark figure, and you can use it, and you have a good chance of getting it right without actually looking at a BMI chart. And the other method, of course, is to use your smartphone. You can use this for BMI calculation. You can use it to calculate other things like your FIB4 index to calculate amount of fibrosis. You can put in your APRI calculator. I use MD Calc. I'm sure you'll all have your own apps. I use MD Calc all the time. So those are some methods that we can use, some things that we did not have during our days in MD medicine. Now you are at the stage of lab testing. So before we go into the lab testing, let me also explain to you what the liver actually looks like. So when we talk about fatty liver, it's important that we look at the structure of the liver and where the histopathology is going to change. Now you might wonder how Dr. Rajeev is going to explain histopathology without using a single slide. So I have some tricks here for you. So I hope you remember that the liver, the fundamental structure of the liver is called the liver lobule, right? The lobule of the liver, right? So in the lobule of the liver is a central vein. The center of the lobule is a central vein. It is like the hole inside a wash basin. Imagine the lobule is a wash basin, and the central vein is the hole into which the drainage goes through. Now I'll show you how to interpret the lobule. I have a little bit of a prop here. Can you see this? Okay, Dr. Mohan, can you see? All right. Now this is a pineapple. Imagine this pineapple is a lobule, a liver lobule. And I have 3 straws here. Can you see the straws? So one is the hepatic artery, the other is a portal vein, and the third is a bile duct. Now imagine that I'm sticking these at various parts outside this pineapple. Now it's physically impossible for me to do that. So I'm just going to keep the straws on the side. So now I'm going to show you something very dramatic. I'm going to cut this pineapple. So here's my knife. Can you see the knife? Yeah, that's my favorite knife. I use it to chop mangoes. So here's the pineapple. I'm going to cut it. All right. You can see the pineapple.
Yes, sir.
See? There you
Yes.
go. Can you see the pineapple?
Yes, sir.
Okay, I'll bring it real close so you can see. You see
Yes,
this part?
Yes, sir.
That is central vein, and this is the lobule. You see these holes here?
Yes, sir.
Those are your portal triads. So all your blood vessels are stuck there. You see the blood vessels go like this. The portal vein, the bile duct, all these are in the periphery, and they all drain in this direction. So I'll show you how blood drains into the lobule. See, this is the portal, the hepatic artery, and then you can see the blood coming down. You see the blood coming down, and the blood comes down into the center of the pineapple, and the blood drains out into the, you can see the, yeah, I think you can see it now. You can see it now, yeah. Now the blood flows in this direction. So the oxygenated blood comes here, and as it reaches the central vein, the amount of oxygen actually is a lot less. So this is the fundamental structure of the liver. This is the anatomical classification of the liver. And you will also know something called zone 1, zone 2, and zone 3. Now, zone 1 is, that is a functional classification of the liver, physiological classification. This is structural. Lobule is a structure. Now, portal triads are around, and you can see the central vein. That's the liver lobule. Now, the zones that are close to the big blood vessels here at zone 1, and in between is zone 2, and the zone close to the central vein is called zone 3. But that is actually going all the way into the IVC through the hepatic vein. Now, why did I show this pineapple? Because in zone 3 is where you see the first changes of Nash. In fatty liver, you'll first start to see the liver cells start ballooning. And just to emphasize, I'm going to show you, this is my daughter's balloon. See the balloon? All right. Now, ballooning is the classical feature of histological feature in a case of fatty liver. And as the liver cells, the hepatocytes start ballooning, soon you will start seeing what is called inflammation. And what inflammation? You see the soda bottle here? All right, I'm going to open the soda bottle here. Can you see that? Yeah, all right, here we go. So now take a sip. You see this cap, soda cap? You see that? Now, this looks exactly like the T lymphocyte. You see the edges on the side? The sharp edges? Now that is an activated T lymphocyte. So that is chronic inflammation for you. So along with ballooning, you see these T lymphocytes or mononucleated cells. You'll see them in NASH. Now, as the disease progresses, more and more of these cells come. A small amount of cells is okay, but when a large number of these cells come, that is really what we call NASH or steatohepatitis. So with just the ballooning, we call it fatty liver. When these cells come, we call it NASH. And when the cells come, eventually the liver is so unhappy, it is so violated, it starts responding, the fibroblasts start proliferating and they create what is called fibrosis. You see, I live in Kerala. You see this? Now this is fibrosis for you. See that? Can you see that? Yeah. This is fibrosis for you. So when the liver gets a lot of these inside the liver, you call it fibrosis, and these are made of collagen. And when the fibrosis is so organized that the liver architecture is completely destroyed, then we call it cirrhosis. And in NASH, this fibrosis, see this, we call it the coconut husk. It is actually focused around each individual hepatocyte. So around each hepatocyte, this husk will come and get deposited. And now that, if you remove the hepatocyte, it looked like what is called a chicken wire mesh. You remember when you keep the chicken, you keep a wire mesh, like a hexagonal wire mesh, right? So when fibrosis is seen using a reticulin stain as a chicken wire mesh, and that's a classical feature of NASH. So that for you is a little bit of histopathology for you for NASH. So I've explained the histopathology for you, and now I will go on to treatment. So you want to treat this patient. Okay, we've discussed all the theory, and I'll discuss this treatment for you. Most people develop, let's just say this person does not drink alcohol. If this person does not drink alcohol, this person got NASH because A, the person is sedentary, the person's dietary habits are not good, the person's exercise habits are almost non-existent, or maybe just for namesake. So those are the three factors we need to correct. Now, how do you actually correct that in just a brief interview? That's why I said many of these patients require a long-term follow-up. Remember, I never even mentioned a medication, all right? Which is why I said root cause analysis. We should always go back and find out why the person got the disease, and then go back and try to fix that problem. We can't make him lose his job because he became sedentary because he lost his job, because he got his job. We can't make him lose that job. But within the job, while having the job, we should educate him on how he can get around that. Now, a study was published in the Journal of Hepatology. This is an extremely important study. Again, it's not a very glamorous paper, but I loved that paper. They looked at 150 patients with NASH, and they randomized them into two groups. One group got just what I discussed. You know, patient and me sitting and talking. I tell the patient, please eat healthy, please exercise regularly, eat less, exercise more, eat a healthy lifestyle, and come back and see me in 3 months. The other group, about 75 of them, were designated to a weekly monitored follow-up program with the clinic, with the dietary clinic, and somebody was actually talking with them, monitoring the dietary intake, and also asking them about their exercise habits. Guess which group did better? The group that got the doctor's advice got almost nothing, about 2%. The other group, 7%, achieved the target And the target was intrahepatic triglyceride content they measured using MR, and they found that the target was achieved in 7%. So this shows that a single visit or a single bit of advice will probably be of no use to this patient, and long-term follow-up is needed. And as a doctor, we don't exist alone. We need to call the dietitian. A dietitian is someone who has profound knowledge in things that we doctors know nothing about. They will sit with the patient, analyze their dietary preferences, their social circumstance, their kitchen, and they will discuss what changes can be made in that patient's dietary plan. So it's very important to involve a dietitian in this patient's habit. And how else do you manage this patient? As I told you, it's a tip of the iceberg. Underneath the iceberg, there is hypertension, there is diabetes, there is heart disease, and there could be hidden stroke there, hyperlipidemia. And to make it worse, the patient may be drinking and smoking. So imagine all of these things put together. Remember the FBI picture? The patient may be headed for an early death or a chronically ill-looking person. So sitting in your OP, outpatient clinic, you have the power to change all of that. So what labs do you order? You do your complete blood count, because if your platelet count is low, then we can assume that there is some fibrosis setting in. The platelet count below 180,000, you want to look very carefully at it. And platelet count, as you know, is also part of the APRI index, all those calculations. You can pick whatever index you want to detect the amount of fibrosis on the patient's liver. And you want to detect cirrhosis at the early stage. So you can look at all the changes I mentioned to you about the phase, the profile of the patient, examine the patient's abdomen. Is the liver shrunken? Is the liver enlarged, hard? Is the caudate lobe enlarged? Is there a spleen? Is there ascites? And if you think the patient has liver disease, chronic liver disease, you might want to get the patient in touch with a transplant program if the patient is able to afford that. You know, affordability is a big problem in India. But remember that in terms of all the transplants done in the world, NASH-related cirrhosis is number 2 now. Alcoholic liver disease still is one of the most common causes of liver transplant. But NASH is getting up there. So now we'll come to the last part. As I said, this is not, I don't want this to be a pill-based. We have a pill, and what pill do you give? Because time is short, I'll say this. The commonest prescribed pill in India is not recommended for fatty liver or NASH. It is ursodeoxycholic acid. No, it is not licensed for use. It is not approved for use for this condition at all. It's only approved for use in primary biliary cirrhosis, which is an extremely rare condition, which you might see 1 or 2 cases in your lifetime. Now, but the commonest prescribed drug, it is still ursodeoxycholic acid. A newer agent is out. It's called obeticholic acid. There is a paper out in Lancet that was funded by the makers of this agent. It is not FDA approved, but it's available in India for a cost of around ₹35, which is around the cost of ursodeoxycholic acid. And at a dose of 10 milligrams or 25 milligrams, it is believed to reduce the fibrosis, but it actually causes a significant amount of itching to the patient and can also upset the cholesterol profile of the patient. So obeticholic acid is I'll call it a substance of interest at this point. Many doctors are prescribing it, but I want you to know it is not an FDA approved product yet. The FDA approval is now delayed because of the COVID pandemic, because everything else is around the COVID pandemic. Do not forget the cardiac evaluation, because younger people are getting heart attacks now. They are dying young because heart disease is not picked up at a young age. So remember the iceberg I mentioned? The bottom of the iceberg could well be heart disease. The patient may be showing you an ultrasound that shows fatty liver. And if you're a smart doctor, you'll pick up early coronary artery disease and make primary interventions which can make the patient's life longer. So remember, have a low index of suspicion for heart disease in this age group. Always rule out diabetes, because as you know, the fundamental cause of fatty liver still happens to be centered around insulin resistance. And as you know, diabetes and insulin resistance go together. So look for features of insulin resistance. Some of the clinical features include a darker pigmentation on the side of the forehead, a darker pigmentation behind the neck. It is called acanthosis nigricans. So it is a loose marker of insulin resistance. If you see that in an obese individual, think insulin resistance. If you see that in an obese young woman, think polycystic ovaries. So those are some of the pointers I have for you. So to summarize my talk, I'll go back to the conclusions. In case somebody walked in late, I'll go to the conclusions and read out the conclusions once more. We should not assign patients or diagnosis into boxes. No diagnosis is any longer confined to a box. With each diagnosis, if we look carefully, there will be interrelated diagnosis. Just like for fatty liver, there can be heart disease, diabetes, cerebrovascular disease, hypertension, even renal impairment. We are a pill-based society. The patient may push you to give a pill, but a pill might not be the answer. The only proven solution for non-alcoholic fatty liver disease, Nash or Nafld, is sustained weight loss of 10%. That is the number 10 I told you in the beginning. Remember the number 10. If you can get this patient to lose 10% of the weight, no pill is ever necessary for that patient. And every patient with fatty liver, remember the iceberg I told you. This patient is the tip of the iceberg. How much you uncover, it's about how good you are. And it is not a single visit case. You must give them follow-up visits. Give them time, ask them to discuss with you. Each patient may have a different question, may have different fears, and please do not make them more anxious than they were in the beginning by using jargon. So on the one hand, if you reassure them too much, they may go back to drinking lots more. If you scare them too much, you're spoiling their quality of life. And last but not the least, just to repeat myself, liver function tests are an extremely limited commodity. No matter how much you tweak them, they're after all a few numbers that should rightfully be called only liver tests. If you know them well, it's good, but remember to interpret LFTs for what it's worth and pay special attention to AG ratio, which is again something that people tend to overlook. In chronic liver disease, you'll find a broad rise in the gamma globulin levels. So keep AG ratio in mind. That's one way I've picked up several patients with chronic liver disease where all other lab parameters were normal. So in the interest of time, we have 3 minutes left to 4 o'clock. I'll stop now and I take questions. Thank you.
Thank you, sir. So thank you, sir. There are some questions are coming in. So the first question is, what about role of bariatric surgery?
Yes. The role of bariatric surgery, I'll explain when it comes to weight loss, there are 3 tiers of weight loss. The first tier, I took you through only to the first tier because we don't have a long session here. The first tier is what I told you. It is not just enough if you sit and talk with them about what I show them. This. You see, this is a dinner plate. I'll tell you very briefly about the diet first. Tier 1. The ideal plate, ideal meal. You ask them to take a dinner plate, draw a vertical line through it. To the right half, you put in your vegetables. The other half, you divide into 2. This quarter is your carbohydrate, which can be your rice, your upma, your idli, dosa, whatever it is. And this quarter is your protein. All right, that can be a meat, egg, chana, legumes, fish, whatever. So protein here, carbohydrate here, vegetables that don't include potatoes. All right, potatoes are not vegetables; they are starches. So starches go here. So if you can ask them to use this plate, that's a good way to get them to restrict eating. So that's tier 1. Tier 2 is intragastric balloon. That's something that we gastroenterologists do quite a bit of time. And intragastric balloon is something we place to through an endoscope. We do them under anesthesia in the theater. And the balloon is the size of a cricket ball. It stays inside the stomach for a period of 6 months, and they lose an average of 15 kilograms. Very few side effects. Many patients lose weight. On average, the weight loss is 15 kilograms. So it can be taken out safely at around 6 months. So they lose weight. So that's good. Tier 3 is bariatric surgery, and bariatric surgery can be of different forms. One, the commonest done here, I believe in India, it is reducing the size of the stomach. We call it sleeve gastrectomy in this part of the world. And there are some other stapling devices as well. Right. So what does bariatric surgery do to NASH? It's a well-studied topic. Again, the results depend on what publication you read. If you read the surgeon's publications, they will say that bariatric surgery is excellent for NASH, and all the problems of NASH go away. Now, as to what problems go away, it's shown that almost all the fat and almost all the inflammation goes away. But what is worrying is in about half the trials, that is 4 out of 10 trials which are of good quality, none of them are randomized, but 4 out of 10 trials, they show a worsening of the fibrosis. And this has caused a little bit of alarm among the gastroenterologists and also with the Cochrane database that looks impartially at all of these reports. So to put things in a single sentence, I'll say bariatric surgery need not be done for NASH alone, but if it is done for other reasons, NASH will go away, but keep an eye out for worsening of fibrosis. Next question.
So what is the role of vitamin E, Pioglitazone and Metformin in patients with Nafld?
Okay. Now we are talking about the pill-based society here. Everybody wants a pill, right? If you don't give the pill, the patient is unhappy. The patient will go to the next doctor who will prescribe 10 pills and say, look, that's the best doctor. That is an unfortunate reality in India. But that should not stop you from practicing what is right. So back to the question. I mentioned that UDCA is of no use and should not be used. Number 2 is vitamin E. Now, vitamin E is considered to be helpful in non-diabetic NASH. Non-diabetic NASH, all right? Now, vitamin E, I'm happy to say it's one of the cheaper drugs that are available. It costs actually very little money, right? Compared, it's about 1/10 the cost of ursodeoxycholic acid, or even less. So vitamin E may sound fancy, made by reputed companies. It comes at a very, very low cost, below 5 rupees. Vitamin E, as I mentioned, is authorized for use for non-diabetic NASH. Now, it is not considered harmful in diabetic NASH. It's just that it's not been studied enough. It has not been studied well enough in diabetic NASH. Metformin for NASH, the first paper on metformin and NASH came out of Johns Hopkins University when I was there in New York. It was done by my senior, Dr. Satish Nair, who was an alumni of Trivandrum Medical College. So Satish and co, they studied a small number of patients, but it's still a landmark because of the first paper that ever looked at the role of metformin in NASH. Now, Satish demonstrated that the enzymes actually came down with the use of metformin. That study generated a significant amount of promise, but later studies have all been largely negative. So metformin per se might not be a drug that you want to use for exclusively for NASH, but if there is diabetes, obviously the patient will be on metformin and it will be of some use. Now, metformin, the exact mechanism of action is largely unknown, but it does have the property of making the liver a little bit more sensitive to insulin. And that may actually help the process of NASH and may help improve NASH. So that's about metformin. Again, an extremely cheap medicine. It's ridiculously cheap. In fact, it's about 1 rupee 50 paisa or something like that. Extremely cheap medicine, metformin, the generic metformin. Of course, there are fancy versions. So again, always keep the cost in mind. So would you want to give the 1 rupee 50 tablet or the 35 rupee tablet? When you multiply it over 6 months, you see the difference it makes. So imagine if you put that money in the post office. So you'll have a significant amount of savings at the end of that. So keep all that in mind when you practice. And a good way to keep track of your cost is to use 1mg. 1mg is an app that I use. A quick check at 1mg will look at all the options of what there may be some cheaper options, but cheap need not necessarily be good in India. I want you to know. So that's a big topic altogether. So back to your question, pioglitazone is the other drug that was asked. Pioglitazone is one of the agents that's been proven to be helpful in NASH and in diabetes. The only problem with pioglitazone is that it makes people gain weight. So keep that in mind. As long as a patient does not gain weight, in a diabetic patient with NASH, I would be in favor of using pioglitazone. Any other questions?
Yes, sir. Next, there is a comment also. Thanks, sir. What is the significance of grading the fatty liver as 1, 2, and 3?
It's of no significance. Ultrasound will give you dramatic pictures of grade 1, grade 2, grade 3. It does not correlate with fibrosis. But on the other hand, it improves the reporting system of ultrasound. It is reproducible. They in fact use objective parameters. Did you know that? The radiologists use objective parameters to distinguish between grade 1, grade 2, and grade 3 NASH, grade 3 fatty liver. So they use the echoes of, largely echoes of the diaphragm and the IVC as to how it contrasts with the rest of the liver to come up with this grading, grade 1, grade 2, grade 3. It is of no prognostic value. And by definition, fatty liver requires more than 5%. But of 5% of the liver must be replaced by fat. Remember the core area that I talked to you about? The core, it comes in the in the perivenous area. The ballooning happens in the perivenous area. The ballooning happens because the fat globules get deposited inside the hepatocyte. The hepatocytes start growing up to become like this balloon. All right. So that's where the fat starts. But ultrasound to pick up 5%, it's impossible to pick up 5% on fatty liver. So if you do find an ultrasound that reports fatty liver, you know there is fatty liver for sure. All right. So that's my point. Ultrasound is very good at picking up fatty liver, but only at a substantially higher percentage of fat replacement.
So there is next question. I think they were trying to ask, I think in India, below how much alcohol use can be a risk factor for NASH?
Say that again. In India, how much?
In India, below how much level of alcohol use can be a risk factor for NASH?
The point that I mentioned, these people are not in boxes. Most people with fatty liver, at least in Kerala, many people drink. In fact, a large number of people drink. And I would find it very difficult to actually find a pure NASH. You know, there may be a few, but the vast majority, I'll say, will be mixed picture. That's my point. There is no absolute number of alcohol to cause liver disease. So what I'll do is I'll send you my articles on fatty liver, alcohol use, and cholesterol and cooking oil to Mohan, and Mohan can send them around to the postgraduates. And each of these are extremely large plain English articles which are written with a lot of references, but they are written in beautiful English, so you'll enjoy reading them. And you know, that'll explain to you what I meant, because it'll explain to you why the arbitrary limits of alcohol are of no use. And there is emerging data that the global alcohol consumption is going up. And in India, with the improvement of the economic parameters of the lower and lowest socioeconomic parameters, the first thing to change, in fact, is alcohol use. They're gonna spend all of that money in alcohol use, and it's going to increase the alcohol consumption in India. So that's a big topic in itself. But the short answer to your question, there is no single limit. You tell them do not drink, that's the right thing to do. If you tell them drink a little, they'll be like, the doctor said I could drink. They'll take the little out and they'll start drinking. That's the reality.
So next question, what proportion of NASH progress to cirrhosis over what period of time?
Yeah, that's an extremely difficult question to answer. I don't have a firm answer to that. And every paper I read generates a different number to that. If you talk with the hepatologists, they would say that about 25% of NASH will go on to cirrhosis over a period of a few years. Now, for me, that's extremely hard to believe, but these are quoted numbers, so I don't really know. The truth, I do not know, but the quoted numbers are perhaps a little too harsh.
The next question, how to evaluate someone who had a family history of Nafld with HCC and the person currently has a fatty liver? Yes.
That's why I said take the family history very carefully. One of the most important things in a patient's history is family history, especially in GI practice. You know, I have a special interest in colon cancer and colon polyps. Some of the work I've done is on those topics. Again, extremely important, because you may not get the history, but if you get the history, it's extremely important. So instead of asking, is anyone else, is there anyone else, or ask them, is there anyone else in your family with liver disease? They'll say no. Ask them, who in your family has liver disease? And if they do have liver disease, if they have had chronic liver disease, I would put them on long-term follow-up, because there are as I mentioned, no two cases of fatty liver are the same. And a person with a significant family history may progress more readily to the chronic liver disease, cirrhosis, and hepatoma, as opposed to someone who is not. So, which is why I said that his early history taking and your risk stratification holds the key to the patient's future. If you're not kind enough to take a good history, you might just call it a run-of-the-mill NASH, and the patient may come down with hepatoma in maybe a few years' time, and you would have missed the opportunity to prevent that altogether. Remember that if you do have NASH, you could actually get hepatoma, that is hepatocellular cancer, without going through the cirrhosis phase, which is a scary thing to do. So if you look at all the hepatocellular cancers, the number of NASH-related hepatocellular cancers is actually going up. So it is a big problem. So, which is why I said, you're able to prevent cancer in this individual, you're able to prevent heart disease and premature death in this individual. If you do categorize this patient as somebody who requires cancer screening, please put them into cancer screening. 6-monthly ultrasound and an alpha-fetoprotein will take care of it. At least 6 monthly, or minimum case once a year. Once a year is better than nothing, but it's better to do every 6 months.
I think you just answered that, I think, sir. There is one question. How often would we recommend repeat ultrasound imaging for a patient with fatty liver?
Yeah, I would not want a repeat ultrasound. It always takes you to the first question. Why are you doing an investigation? See, that's an area that I wanted to cover, but I did not have the time. It'll take about 10 minutes to cover that. Remember, whenever you order a test, ask yourself this question. Is this test going to change your thinking? Is it going to change the management of the patient? And so those are two fundamental questions before you order an investigation. Now, there are other reasons to do a test. For example, monitoring. Somebody on azathioprine, you wanted to monitor the cell count. Somebody on steroids, you wanted to monitor the blood sugars. Then you can do for screening. For example, you do a colonoscopy in somebody who's over 50 for cancer screening. If you do a mammogram on somebody who's 40, who's screening for, say, breast cancer. But back to this question, why would you want to do an ultrasound on a healthy, otherwise healthy 40-year-old who has no risk factors? And why would you do that? It's not medically necessary, but in practice, I see it being done. And sometimes the patient is happier. If you do a lot of investigation, some patients tend to be happier. But medically, it may not be necessary. But in high-risk cases, for example, if you suspect that the patient may progress to liver disease, if you suspect that the patient needs to be put on a hepatoma surveillance program or a hepatoma screening program, yes, definitely yes, you should bring them back in 6 months or a year. But for the vast majority, personally, I would not repeat an ultrasound unless there is a compelling reason to do so. You can always get the data you want from A, the SGOT-PT, and B, the patient's weight, and also the waist circumference. Why would you want to do an ultrasound?
So next question, what is the role of liraglutide in NASH?
Yeah, the role of liraglutide has been studied. I'm not very clear of its present role. It has been studied. It's been around for a few years. But specifically about NASH, I'm sorry, I do not know the present status.
Next question, sir. In a patient with NASH liver disease post-transplant, does NASH come back?
Yeah, it's a very good question. NASH does come back. There have been cases where fibrosis has set in, leading on to cirrhosis in a transplanted liver. And so those cases have been there, but we don't know the denominator. So we don't know the total numerator, we don't know the total denominator. So in other words, we can't predict how many of these people will eventually get into repetition of NASH. But I'll tell you the unfortunate reality or unfortunate truth behind this statement. See, for somebody with NASH cirrhosis to get a liver transplant, unfortunately, as I mentioned earlier, many of them have significant heart disease. So they spend longer on the waiting list for liver transplantation. And after liver transplantation, during liver transplantation, because of their comorbidity, they may have a slightly higher risk of complications. And their longevity will not be very good compared to other patients because they also have the additional cardiac morbidity. So before they get a chance to get NASH-related cirrhosis, some of the disease might take their life. That's the unfortunate reality.
Sir, is there a role of colchicine use in NASH?
I do not know. Sorry.
Yes. Sir, is there any specific diet to be followed, and what is the kind of exercise to follow in patients with NASH?
With NASH. Okay. So as I said, I will send you my article on cooking oils. You will get a lot of questions on cooking oils, and it is perhaps the most elaborate work written on cooking oils yet. I'll recommend you to read it because it contains A to Z with zero commercial bias. All right. So I'll summarize the cooking oils in one sentence. No single oil is very good. No single oil is very bad. Reused oil is terribly bad. Trans fat is bad. So to get a healthy mix of oils, use the least possible, but use different oils for different purposes. I hope you got all of that. Now back to what to tell them. Send them to the dietitian, all right? Send them to the dietitian, because if you can't send them to the dietitian, show them this plate. Keep a paper plate in your clinic. It's easier to show with a paper plate. Draw a line, vegetables on one half, rice only in a quarter. At least in Kerala, they take 2 heapfuls of rice in 2 plates, and maybe a 3rd heapful as well for lunch. So that's huge, an extraordinarily large amount of rice. Now that's not necessary. Now, of course, for a laborer that's doing hard manual labor, that's different. I'm talking about the regular sedentary professional. And this quarter for protein, and then you add a fruit serving with that if possible. So that is the ideal plate, and no second servings, all right? No second servings.
Sir, as there are no further questions, I would like to hand over to Dr. Tambu, sir.
Hi, everyone. I hope you can hear me. Hi, Rajeev.
Hi, Tambu.
That was excellent, Rajeev. Wow.
Hey.
You're the same old Rajeev. Man. I think now the audience will know why we were so thrilled and blessed that you took our offer up and took the session for us. Fantastic, Rajeev. It was like the old days in I think 1995 or 6 sitting
rooms,
there.
Right? We used to sit and discuss these things. Yeah.
Good old Medicine 2 conference room and discussion. So thank you again, Rajeev.
You're welcome.
We really enjoyed it. I hope if there are any questions which come, we can pass them your way. Yeah. And maybe we can have another session on cooking oils. I think that's another hot
definitely.
topic.
Why not? We can do that. Yeah, we can do that. Cooking oils that's a great topic, because as doctors, we don't really know. I realize even as a doctor, I did not know much about cooking oils. It's a big topic. It's worthy of a textbook in Harrison's, really.
Wow.
So and maybe that's as a disclaimer, I'll say this. To do a lecture like this without slides is extremely difficult. And it's on a complex topic like NASH, it's a big gamble. But I'm known for doing unconventional things, and I know I can pull it off. So I'm sorry for my pineapple.
No, we enjoyed it. I think these things stay more with us than I think people. They do. PowerPoint. Thank you, Rajeev.
Anybody can do, but to do a direct talk like this, it's very difficult and challenging. I did work very hard for this one. Yeah.
So thank you, Rajeev.
You're welcome.
Thank you very, very much. So we should see you in person soon when COVID is over.
Sure.
Until the time, greetings to your family as well. So thank you, Mohan and team. Thank you to the telemedicine group. And see you all next Friday. I think we're going to have on reversing diabetes with lifestyle, a talk by Dr. Samuel Hansduck, our head of lifestyle medicine unit. So if you're available, please come and join us for that as well.
Please send an invite. Yeah.
Yes, we will. Yeah. Okay.
Thank you. An honor and love to all of you. Stay safe, and just stay safe. And all this will be better in a few months' time.
Thank you, Rajeev. All right. Bye-bye, everybody.
Bye-bye.